Anders Brier, he's a medical doctor and a PhD student at the Research Unit for General Practice at the Institute of Public Health here at Aarhus University. And as part of his PhD, Anders has been involved in some really exciting work relating to perceived stress. So that will be the topic for the next talk.
Yep. Okay. Yes. Thank you for having me here today. It's a great opportunity to have a completely other angle of stress research, I think. I'll be the one who's not mentioning cortisol at all. I have no pictures of the brain. But, so what's left, you'll say maybe, but I'll talk to you about our research on perceived stress. I'm not a neuroscientist, but I'm also not an anthropologist. I'm just an ordinary MD, going to be a general practitioner in a couple of years. But we know in the clinic that we have a lot of patients presenting with stress-like symptoms. Sometimes we call it depression, anxiety, but there is, in the general population, a lot of people who are experiencing stress, and that's, for us, very exciting. So, let's see if this one works. Yeah, this is in Danish, I'm sorry. It's just a newspaper clip about all the Danes being increasingly stressed and the scientists struggling in understanding the biological background, but also in understanding the stress perception and what's the importance of this concept. And that will be my start of this talk, and I'll get into the relation with comorbidities and also mortality a bit later. So, stress perception is subjective as opposed to, for example, biological markers of stress or brain scans and stuff like that. So that will be our focus. This is very basic actually, but very important in understanding the effects of perceived stress. Effects of perceived stress are assumed to occur only when both the situation is stressful and if there are insufficient resources to cope with it. And part B here is as you might know, very important. And I'll compare it to the concept of external stresses or major life events research that we're also doing at our institute. And actually, external stresses are a bit easier to work with. They are well defined in time, but there are some sense of objectivity to the stress that assume that, for example, the loss of a spouse is a stressful event. Often it is, but it might not be, as Dr. Herbert just pointed out. On the contrary, perceived stress effects are much more related to conceptual factors and personal factors, lifestyle, network, and from our point of view, it's the focus on the individual that's interesting for us. So I'll let you test your stress level this afternoon. No, you shouldn't go through the. But this is the instrument that we often use to test perceived stress. It's called the Perceived Stress Scale. It was developed in '83 by Cohen, and it's quite well validated and often used, and has been translated into numerous languages, including Danish. It's a sum score with questions about, and it aims to measure the degree to which situations are appraised as stressful, taking the feeling of control into account. So there are just a question in the last month, how often do you feel stressed, but there's also a lot of questions about control, the feeling of control, for example, things that you could not cope with, and where you're on top of things, stuff like that. So it gives a score on a sum score from 0 to 40, 40 being those with the highest perceived stress level. So it's the instrument that we often use. And fortunately in Denmark we have a lot of data on this scale because it has been used in what's called the National Danish Health Survey of 2010, in which nearly 250,000 Danish citizens were asked to fill out a questionnaire on perceived stress, but also about lifestyle factors, self-reported health, and socioeconomic factors. So it's a great thing for us to use as a resource in our research. So just the Danish version of the perceived stress scale. For our research, we included 120,000 Danish citizens from all Danish regions. And just on the descriptive level, we found that elevated stress levels were predominant in those with female sex, what we call women. Those with unhealthy lifestyles such as smoking and physical inactivity, low educational level and unemployment. All of which is not that surprising. So, and it wasn't the focus of our research, but it's nice to know that there are some confounding factors related to stress. Okay, and it might be a bit difficult to see, but here you see the actual stress distribution in the study population. And I have a median here about 13, 14, and a tail here with those with very high stress levels. And it's not really a scale that has been, there's no threshold of high stress level, but we use the 5th quintile and we call them those with high stress. It's the general thing we see in the literature. And we'll use that a bit later in the talk. So that was just a bit about the stress perception, and I'll go on to talk about the relation to illness. This is actually important in clinical practice. Stress is just something that you experience yourself, and should the doctor do something about it? If it is important for the prognosis of your chronic diseases or your lifespan, it might be important to take into account at the GP's office, but we'll see. This is the typical GP waiting room, just to give a sense of who's going in and out. 50% of patients will have a chronic condition, and half of them will actually have 2 or more chronic conditions, what we call multimorbidity. But what's very interesting is that nearly half of our patients will have mixed psychological and physical reasons for encounter with their GP. So psychological things and mental well-being plays a big role in every consultation at the doctor's office. Just a note on multimorbidity. More and more people in the Western world, and actually all over the world, will accumulate more and more chronic diseases. People are getting older. Things are being, diseases are being diagnosed earlier, and treatment is better. So multimorbidity is actually here to stay. And what we think is important is this layer of mental well-being that is very important when we think about people with a very high disease burden. So stress perception and the healthcare system. In Denmark, it's we have the patient interacting with the general practitioner, and most chronic care is actually carried out in general practice. And only when thing gets out of hand, referrals to hospital is needed, or specialists. So in the prognosis of the chronic conditions, this relationship is very important. So we thought that maybe, and this has not really been a focus before, but could the stress perception of the patient actually influence this relationship and maybe lead to a poorer prognosis? We've heard a lot of physiological stress, and we know that there's a strong correlation between the perception of stress and physiological stress. So that could mean something to the prognosis of the chronic conditions. But stress perception could also impact the chronic care and the cooperation between the patient and the doctor. Could that maybe lead to more hospitalizations that might have been prevented because of suboptimal chronic care, and maybe even to higher mortality in the end? And the two last things were what we wanted to examine in some of our research studies. That could a high level of self-reported stress lead to more potentially preventable hospitalization and to higher mortality, taking the burden of disease, socioeconomic factors and lifestyle factors into account. So this is a setup that we have in Denmark. We have a lot of registers that we can link on the individual level. So we have very good and timely, well-defined diagnosis, for example. We had a lot of registers that we could link with the personal social security number, and we could link that to the respondents from our survey. And we had data from registers on 39 different chronic conditions, both mental and physical conditions, socioeconomic factors, hospitalizations, cohabitation status, and also vital status. And we could use this in a longitudinal study, so we had a follow-up of about 4 years from the survey data in 2010. So could we use this to answer our questions? This is the first thing we found out, that actually the number of chronic conditions was very much correlated with the mean PSS score, this perceived stress scale score. And it's not that surprising because, as we know, stress can lead to disease, but having disease is also very stressful. And this is cross-sectional, so we don't know something about the causality of this. But we can see a very strong association here, and we could use that in our analysis later. Now this is a bit more interesting. This graph actually shows the PSS score of our 180,000 participants, and this is the risk of being admitted to hospital for what we call potentially preventable hospitalizations. And it is defined as hospitalizations that could have been prevented if chronic care of a certain number of conditions were performed optimally. And that is, for example, amputations for diabetes, diabetes-related amputations. If diabetes is properly treated, amputations shouldn't be necessary. So what you can see is that we have a threshold here, and then the risk just keeps rising linearly with the stress score. And that is actually adjusted for both age, sex, and a lot of different baseline conditions and predisposing conditions, and also socioeconomic factors. So what you see here is that actually the stress scale is a independent predictor of some sort of poor quality chronic care. Maybe more interestingly, also the PSS score in the participants were closely linked to all-cause mortality, and in the same way we have the score here and have the risk of dying here, and we see that with the score the risk of dying just keeps increasing with the score in a quite linear way. And again, we adjusted for all the things that we think could confound this association. We went on to look at the relationship between psychiatric disease and stress perception. Because of course we know that people with psychiatric disease have a very high stress level, and we could also see that in our data. But on the contrary, even though psychiatric illnesses is not that uncommon, there are quite few in the background population compared to those with high stress. So we took the whole of our study population and divided them into those who actually had a psychiatric diagnosed disease, and the rest who were just stressed, and put them into 5 quintiles. And we compared those with psychiatric disease and those with high stress in absolute numbers of deaths. And we actually found that the number of deaths directly associated with either stress or psychiatric disease was actually a bit higher for those with stress, simply because there were so many people in the background population with high stress levels. So from a public health kind of perspective, it is interesting that even though the risk of dying from psychiatric disease is quite high, it's fairly uncommon, and those with high stress actually are associated with more deaths. So, just a bit of a summary of some of our findings. High stress levels were associated with female sex, unhealthy lifestyle, low educational level, unemployment, but also with an 45% increased risk of dying, and with 40% increased risk of these preventable hospitalizations. And we saw quite a clear dose-response relationship between the perceived stress level and these outcomes. And so this is another angle of stress research. So could we try to link it to find some explanations, because we had no data on genetics or biological markers and stuff like that. But we think that, again, it has been mentioned before, that the allostatic load theory is a good framework for actually explaining some of these findings. In addition to that, also the stress load might change behavior in these patients. They might come less often to their general practitioner. There might be mixed symptoms from both physical and mental disease interacting with the stress perception, making them quite complex to treat. They might not be as good as to adhere to their medical treatment, and there are some behavioral things that's important. So the implications for the healthcare system, from my point of view, is actually that we need to have a biopsychosocial approach, which of course as GPs we're often proud of, not just thinking of the physical disease, but trying to have a holistic approach to medicine. And in this case, I think it's very important. Try to pick up the signals that our patients have about being stressed, and being able to respond to that in some manner. Also, it's important to find, and I haven't showed a lot of figures about that, but we know that those with high levels of disease burden were actually more susceptible to stress in terms of mortality and hospitalizations. So there are some vulnerable patient groups that we need to take care of. Should we do some sort of stress assessment in general practice? And I might as well put that on the discussion topic, because I think that's it's very important to, as a medical doctor, you tend to want to put things into boxes, and you would actually also, maybe it's a good thing to make a diagnosis so you can put it in a box so you can find a treatment. But in this case, I think it might not be the best thing to do. It's important to be very aware of stress symptoms in patients, but it might not be the best idea to just figure out a diagnosis, because it's very what do you call it? It's not very homogeneous symptoms. So just a note on stress assessment: the perceived stress scale has not been validated for use in a clinical setting, so there's no cutoff, for example, opposed to some of the depression or anxiety scales. So it's just a continuum of symptoms. Do we have some interventions that work? Well, it's, to my knowledge, not some that have been tested a lot of on long-term outcomes, but we know that things are being investigated on problem-solving therapy, which is cognitive behavioral therapy light, maybe, and also mindfulness-based stress reduction. Yeah. So, take-home message is that we have some people in the general population who have high levels of perceived stress, but we do not know much about them actually. There have not been a lot of focus on them from the medical society, because they are not diagnosed with the illness, but we see them every day in general practice, and we think they're important to take their mental well-being into account, especially when our research now shows that the stress perception in itself, when we have adjusted for all the things that we can, still is a predictor of things like poor chronic care and mortality. So, and maybe if this is a causal relation, we might be able to prevent some hospitalization and reduce some mortality in our patients. So, and a couple of references, and yeah, I think that's it.
Of course, it's an assumption, and a very reasonable one, that reducing perceived stress is going to have a beneficial effect. Why do you think that?
I'm not. That's a very good question, and I'm actually not sure that it will help, especially if we have an underlying reason, a common reason for the outcomes and for the stress perception. We have to go one layer deeper than just reducing the feeling of the problem. But if we think that there's some sort of positive feedback, that actually reducing the perception of stress also reduces some of the underlying mechanisms. We see a lot of feedback mechanisms in biology, so that might be interesting to test at least. And we know a bit of that from the mindfulness studies that have been that actually reduces only the perception of stress as far as we know. And that's not my specialty, but I know there's someone in the room who can tell a lot about that. Yeah.
Because we're talking here about effect size, aren't we?
Mm-hmm. Yeah.
if you were to reduce your stress, perceived stress by say 50%, what effect size does this have on mortality or on hospital admissions, or even on quality of life? Actually?
I don't know, but it's the problem with this kind of research is that you cannot really. It's very difficult to do a randomized trial. You can't tell someone to not have some sort of stress appraisal. So I'm doing research right now trying to look at this from another angle with bereavement studies where we know that some sort of objective stress is being put on people and using some of the same data from our registers and something like that. But again, you can't do a randomized trial because you can't bereave someone and not bereave a control group. So there's some difficult methodological things in these kind of studies.
You could if you were Syrian.
Oh.
Yeah, you could.
So much. You had your hand up as well.
I don't know much about stress, it's not my field, but I saw that there was one of the associations was education level. What kind of association what kind of association with education level did you see near that?
Low, well, it was an low education level was associated with high stress levels.
High stress level?
Yeah.
I always thought it was the other way around.
And that might be also high stress levels were also associated not with being employed but unemployed. You still, if that's
but can you correct for that in the regression model?
Yeah, we did.
But it's still you fall out.
Yeah.
You'd expect that. You'd expect that people who are low education have more problems in life, less resources, so they're more stressed.
Yeah. And that's actually just a small note that the perceived stress scale is quite good as measuring a global stress and not just a work-related stress or relationship-related stress and stuff like that.
There's a question over there, Alexander.
It's just an observation on the Danish healthcare system and its attitude or non-attitude to stress.
Yeah.
The Danish healthcare system does give financial support to people for treatment of anxiety and depression, but not for stress.
No.
But so what you're implying is there could be a bias in the data in terms of how many people you're seeing coming forward, or people pushing?
No, not at all. I mean, if we look at the problem from a national health problem and mortality, then more support from healthcare system to people with stress probably would be very helpful.
Okay. I think there was another hand
Well,
floating.
I was just going to add to that you know, that would also explain why you see more in the was it the fifth? No, the people that have 5 or more points. There may be psychiatric illness there as well that is not diagnosed.
Yeah. We were able to adjust for diagnosed psychiatric disease, but of course not undiagnosed. But there's most certainly some sort of overlap, especially in those with high stress that might actually have a diagnosable major depression.
I'm very envious about these national data sets.
Yeah.
I'm very impressed and very envious. This is available to the university or to anyone in the center? Or?
It's actually everyone in a research institution. You have to apply and it's anonymized.
Let's get a collaboration going.
Those are very good numbers. I mean, when you present that association, that's a very strong finding because of the numbers that you have there. I mean, that's a really strong finding. That's very good.
There's a question here.
Yeah, I was just wondering if as you were talking here, when we're returning to the question of perceived stress, isn't that a good in itself, or isn't that part of a definition of quality of life? I'm totally outside the field, so I'm just wondering if we don't use that.
I think there would be some overlap in some of the questions. In this data set, actually, we used also the SF12, which is also quality of life sort of scale, and we did run some analysis using that scale instead of PSS, and the findings were similar. So those with high stress level had low quality of life in general, but we haven't dig a lot into that. But
in your data on this perceived stress state, those correlational things like low education, was there any correlation with the religiosity and spirituality? Because they claim often that changes your temperament. And
it could be very interesting to examine, but we didn't have any data on it. There were no questions about religiosity in the survey, and we can't get that from the registers.
Okay. That was never asked.
No, exactly.
Well, the church tax.
Yeah, maybe. If we can get access to
just
the
clarify
tax.
this for the international members. Do you mean whereby you have to state that you're part of Lutheran Church, so you get a state burial? Is that recorded?
Yeah. If you're a member of the Lutheran State Church in Denmark, you pay church tax.
Right.
And that information would be in the registers.
And then you're less stressed.
Of course, it would be a dichotomous measure.
And
you
it
could
might.
have some indicator.
Denmark is not a very religious country, so actually being in the Lutheran Church would actually, and this is just my personal opinion, they might be less spiritual than people in other, maybe Catholics or, I don't know.
Usually religious people are much more aggressive and intolerant and all that.
Please give a hand to Anders. Thank you very much.